PMC in Pittsburgh, Pennsylvania, and here to talk about patient setup and treatment delivery for intracranial SRS. So we'll talk about fixation and mobilization for these patients, both invasive and non-invasive forms. We'll talk about margins and uncertainties, which really go hand in hand, and the concept of end-to-end or E2E tests in determining these uncertainties. We'll also talk a bit about the uncertainty for treatment of multiple metastases in the brain as well. I'll briefly talk about planning for multiple met treatment and how it is affected by these considerations for mobilization and IGRT. And then we'll go through just a few quick treatment examples of things we've seen. So for cranial mobilization, you need to definitely consider stability of the system, reproducibility for fractionated treatments, ability to verify the patient in some form, either with coordinate frames or with IGRT or both. These treatments often extend a long time, so comfort can be an issue, certainly, for the course of treatment. And you want to have some way, of course, of monitoring the patient during treatment, interfraction motion, and minimizing or correcting for it. So options exist for both frame-based invasive frames or frameless mobilization. Frame-based gives you the highest geometrical accuracy. It's sub-millimeter even for long treatments, and it really does, of course, greatly limit involuntary motion during treatment. But that frame itself may be, of course, bulky, may interfere with some beam directions, and especially in clinic-based SRS. And it requires a very tight schedule. The limitation there is you need to do the scanning, planning, and treatment all in a single day. And so this requires good coordination of the entire clinic. Also, you really do want to inventory that all the necessary materials are available at least the night before treatment. For frameless systems, you can get good geometrical accuracy as well if it's done well. That is, you can still achieve definitely millimeter accuracy in the cranium, but it really does require you to use some form of IGRT, and also interfraction imaging is really strongly recommended for some other form like surface tracking. But it allows you a much more flexible schedule for imaging and treatment. It allows you to do hyperfractionation as well, to do things in 3 or 5 fractions. You can scan the patient and then take your time planning and curating the treatment and then treat them sometime thereafter. That said, the targets, of course, may change between simulation and treatment. For brain mets, definitely you want to start the patients within about 7 to 10 days of simulation. And so that means we definitely do want to get recent MRs, recent CTs, and do the entire process fairly quickly still. But this may not be suitable for all patients. Some patients who are confused or unable to lie still in a mask. It'd be very hard to achieve millimeter accuracy for these patients. In some cases, the frame is the best option that you can have. So an example of a frame-based system we use here, of course, quite a lot in our game center. In this case, the coordinate system is really defined by the rigid frame, which is directly linked to the mechanical center of the machine. So once the frame is on the patient's head, it's very stable, very certain exactly where the patient is going to be. And that frame can define coordinates for CT or imaging, and also the patient position is exactly defined by the frame inside the treatment unit. And so on the right there, I show just patient position in our perfection gamma knife unit.
Hey, Ron?
Yes.
One question. The audio is coming through a little bit static. Maybe, I guess it sounds a little robotic.
Just me.
Yeah. Oh, no. I think it's there's some sort of something with the microphone. But one thing that might help circumvent it is maybe speaking just a little more slowly.
Sure.
And
sure.
I can see if that sounds clearer.
Okay. I will try.
Okay, thank you. Sorry to interrupt.
No problem. So for frame-based fixation on the linear accelerator, one, of course, has to collaborate with the neurosurgeon to place the frame. The application, of course, is limited to the cranium, not to any other part of the body. And this is really used for cases where you require the highest degree of geometrical accuracy, such as trigeminal neurology, in which case you need to deliver 80-90 gray to a small target right near the brainstem. So you must, in the LINAC, of course, have some way to accurately register the framed and mechanical center, isocenter of the LINAC. So one option is shown on the lower right there, a coordinate frame used for localization for, in this case, the BrainLab system, using a paper template fixed inside that masked frame. And this is done for localization for non-IGRT localization. But you can, of course, use IGRT with the system as well to double check that everything is correctly aligned. So some practical considerations putting the frame on. Often the pinprick, putting the initial into the patient's forehead, can be the worst part, the most painful part of the treatment. So we apply a numbing agent to the skin section. Then betadine to the skin, but infection is pretty rare in the scalp. The blood flow is very good. We then inject lidocaine at the pin sites, using a cloth handy to keep drips from getting into the eyes when you put the numbing agent in. We find we get a better, smoother process by using a Velcro loop over the patient's head, holding the head ring to support its weight while attaching it. Makes things much more simple. The screws used to fix the frame are plastic, so you want to, of course, avoid over-tightening the screws so they can snap. And when taking the frame off, you don't need a neurosurgeon, but you will need to apply, of course, a cold compress to the pin sites. It's not uncommon for them to bleed after frame removal. Sometimes even a few minutes after the frame's taken off, the patient sometimes just walked away and starts bleeding again. But again, it's not a critical thing, just, again, cold pressure will stop that bleeding. Definitely when putting the patient into a frame, your therapist is going to have to put that patient then into various mounts and couches for the CT, for the MR, for the treatment. And these mounting mechanisms, of course, take some getting used to. So you want to definitely have them practice this process on a phantom of some form in order to get smooth in the process, because it can be very uncomfortable for the patient if they're fumbling around with the patient in that head frame. An example here of a frameless system. This is from the Brain Lab system. So it's a removable mask, still provides very tight, rigid immobilization, but allows for fractionated treatment and does not, of course, require a neurosurgeon for mobilization. So these considerations have really made us mostly go away from frame fixation for our treatments. Of course, we do it routinely at the Gamma Knife, but for Linac-based treatments, we almost always use masks instead of frames. In this particular mask, there are infrared markers, which will guide initial setup and couch motions. And of course, IGRT then is essential to refine or confirm the setup, either CBCT or orthogonal X-rays or both. So in this system, the Brain Lab system, we have orthogonal X-rays shown on the lower slide here. And in this case, they're taken at intervals throughout treatment for interfraction imaging to confirm and then correct interfraction motion with a 6-degree of freedom couch. Of course, this separate imaging system does require careful QA to make sure that its imaging center aligns with the mechanical center of the machine. So another system we've used here is the Cyberknife system. In this case, it's a fairly loose, not a very rigid mask, but in this case, we're imaging the patient almost continuously throughout treatment with orthogonal X-rays. And then the robot delivering the treatment is able to adjust in real time as the patient moves. And so in this case, the more often the imaging is being done, the more often the correction is being applied, the less rigid the fixation has to be. A system we've recently started using here is the Q-Fix system. In this case, it has an open face mask, which allows use of optical imaging guidance during treatment. In this particular setup, we have a pipe lock, which may improve the reproducibility of pitch rotation for these patients. And the system, of course, has reinforced aquablast in this case to make the mask more rigid, improve mobilization. And there are shims inherent in the mask for adjustment of the patient position if the mask shrinks or the patient swells up prior to treatment. So this system can be used then with something like the Vision RT system, where you use optical surface tracking for alignment and monitoring of interaction motion. So again, you'd use typical regular IGRT, CBCT, or orthogonal X-rays to align the patient accurately, first of all, and then use this system to make sure the patient is not moving significantly during the treatment itself by tracking the surface motion. So just some practical CT simulation with the mask system. You want to definitely take the time to make sure the patient is set up as straight as possible at simulation. It's often very hard to exactly replicate a crooked setup. Allow time for the mask to cool completely before scanning. The mask is going to shrink and it may be difficult for just positioning and uncomfortable for some patients. The Q-Fix mask again has its inherent shims for these small adjustments. And you want to make sure the mask conforms really tightly around the patient's head to minimize the possibility of rotation errors. Some masks have a clamshell mask, a 2-mask system, the front and back of the patient's head, or a custom aquaform type cushion can be used to register it, again, both sides of the patient. And in general, the more care you take at the time of CT simulation, the easier and the more accurate treatment it's going to be. An example here from the Q-Fix masks. On the left, a good setup of the patient, his head is resting in a custom head cushion and is well formed to it. On the right, a poor setup, the patient is set much too inferior in the frame itself, and the patient's head is not well supported by that custom cushion. The head is actually sitting on the neck support, and this is not a stable position, and so this patient may have very hard, again, lying still or being held still during treatment. So want to talk about margins and sources of uncertainty in cranial SRS. And there are many, of course. Image resolution, of course, is one factor in it. MR distortion can be a factor, though that's gotten better over the years and improvements in MR technology. The accuracy of MRCT fusion is a critical step, and you need to make a lot of attention to this. That's where we're seeing the most errors in sites just starting out doing SRS is not paying enough attention to very, very accurate MRCT fusion. And this can cause errors which will then, of course, directly transform into geometric uncertainty in treatment. Contouring accuracy, of course, of the lesions themselves in the brain can be an issue. And again, target growth between simulation and treatment may be an issue as well. And there, you do want to limit the time between simulation and treatment to minimize that possibility. The mechanical accuracy of the machine itself, the Winston and Lutz test, of course, can be used to identify that. So that, again, can be one source of uncertainty. Coach motion accuracy, especially for large rotations. One wants to confirm that the patient has not moved with some form of repeat IGRT for large shifts. The accuracy of the MLC motion itself or the cone placement for treatment. And again, interfraction motion may be an issue. And this also has to do with treatment time. The longer the patient's on the couch, the more likely they are to move during treatment. And so, again, using interfraction motion, interfraction imaging can limit that possibility as well. So for MRCT fusion in the brain, we have a rigid system. So automatic fusions do work well most of the time, but there can sometimes be significant errors in rotation, especially in the pitch direction as shown in this sagittal image. We want to use limited field of view to match the rigid cranium only, and check that match using standard landmarks like the tentorium, like the orbits, like the ventral. It's a good idea to use multiple window level settings to display more information to refine that match. So that would include bone and soft tissue windows to, again, get as much information as possible to check that match. So again, for uncertainties, the classic test for doing checks by center accuracy is Winston Lutz test. Here we have a steel ball target at the center, and you're verifying that the couch and gantry kilometer rotation are all within 1 millimeter. Some metric you want to set for that machine. In this case, the film test is not really that quantitative. You can see the error and you can judge from just examples if it's more than 1 millimeter. You can't get a hard number out of this kind of test. And so the result of that test is shown at the bottom of the slide. We have film exposures for a 20 millimeter column surrounding the ball target, just verifying isocentric again for all combinations of couch and collimator and then gantry rotation. More recently, then the test would look more like this. We'll have a cube phantom containing a ball target in the center of that phantom. And there are automated software packages out there to analyze these tests on a regular basis and give quantitative results, which is nice because then you can check the hard numbers and see trends over time if the system is drifting out of tolerance. So it's a better system to do it this way with the quantitative checking. On the newer machines, on TrueBeam, for example, you then have the ability to do more comprehensive checks on a daily basis. So there's a test called the MPC, or Machine Performance Check. That's an automated QA routine that combines imaging, mechanical, and dosimetric checks on a daily basis using, they provide called the IsoCal Phantom and the MVKV imagers. This provides a daily quantitative check, which is very simple to run. The therapist can run it in the morning and physicians can check it later on. And it allows you, again, to take quantitative data to view data trends over time within that software. So there's a regular test that checks, for example, 5 cm couch shifts within a tolerance of 0.7 millimeters and enhanced couch shifts within, let's say, 20 cm shifts, and then displays the results of how accurately that's being done. The tolerances, again, are 0.7 for the simple test and 1.5 for the enhanced test, but the results are often much better within 0.2, 0.4 millimeters. So again, modern couches are much more accurate than they used to be. And also the same test can be checked for couch rotations, for pitch and roll. And again, it's a fully automated test we run pretty much every day. And so we certainly do that every day. Our therapists run that test and physical will check it later on. So yes.
Before we move on to the next part, one of our audience members was wondering if we could review the 2 slides, or I guess the 3 slides before this. It went by a little bit quickly and they want to make sure that they didn't miss anything. Okay. Soha, which was it before this slide?
Yeah, the one before. No, this one, the one after, sorry.
This one here.
Yeah, this one, the isocenter accuracy, yeah.
Okay, yes. And so again, this is the Winston Lutz test as we used to do it. A steel bar target sitting at a center, shown here on this end of this pointer, and then taking exposure through an SRS cone onto a piece of film, and these are the exposures here. And as we run the test, we rotate the gantry, rotate the couch, and rotate the collimator. And so it's all rotating around this point, and we take exposures through that cone again. And by looking at the centering of that shadow of that ball target on the film, we can then get an idea of exactly how tight our isocenter is with, again, the gantry, collimator, couch rotation. And the idea in the film is that we can see, it's a very sensitive test, we can see a change of a millimeter quite easily, but we can't quantitate it that well. So here is, again, a separate system for doing this. It includes a cube phantom sitting on the couch with an embedded steel ball target in this case. And we take exposures, in this case with the MLC, defining a small square field around that ball target. And these exposures are then shown here, taken on the EPID and downloaded into software. And by looking at the centering of that ball within that square field, we can then again see quite easily, of course, visually, we can see that if the ball target is displaced. But we can also use software to analyze that and confirm the displacement in every combination of gantry and coach and collimator rotation. And by doing so, we can get quantitative results, which we then can trend over time. And so we can see if the system is within our tolerance, our spec for treatment on a daily basis, say 1 millimeter, but also if that all localization is trending towards failing that test, we can see if there are changes in the machine over time. And then another test, which again is available on the new machines, is machine performance check on the variant Trubium. This is now available in other variant machines as well. And again, this is a quantitative check which tests a lot of different things in this machine. Again, gantry, collimator, couch rotation, translations as well, and also the MLC leaf by leaf. And so the nice thing here is that this can then really check every mechanical portion of the machine on a daily basis and check if they're within very tight tolerances, 0.2, 0.4 millimeters. And so this gives us a lot of confidence that the system is properly operating and able to treat these treatments to high precision. So,
do we have a same setup on Elekta machines, same as the TrueBeam in those QA routine checkup?
Certainly, these kinds of software are available for Elekta as well. Phantom routine with the IsoCal Phantom. This is not available for other tests that they have for, again, doing these kinds of checks. But this is a very good product.
Okay, thank you.
And so this is a screen showing the analysis of this MPC test. And so in this case, it's showing a film used to verify MLC position. And by doing these kinds of tests and multiple tests, of course, it can actually, check actually each individual MLC leaf every day and show you, in this case, if one leaf is starting to fail, it will actually point that out, highlighted index in this report. And so you can then see if the leaf is about to fail. It'll also show that as well as kind of a yellow highlight. And at that point, you can then call your service person over and they can make that adjustment before anything fails. So a very important test to do during SRS program setup is the end-to-end test. And this is where you take the entire process of scanning, planning, and treatment delivery. And it's used to test the overall total uncertainty in the process of treatment planning and delivery. So ideally, because you use IGRT in these patients, this should incorporate some kind of realistic IGRT setup as well. So the end-to-end is called a hidden target test, where you just take a radiopaque target, like a Winston Lutz cube, for example, and deliver ports to confirm targeting accuracy. But you can also use phantoms to incorporate, say, a chamber or film and also confirm dose delivery accuracy at the same time. So definitely you should do this kind of test prior to first patient treatment and at least annually thereafter. On our, for example, our Cyberknife system, these tests are run on a monthly basis. And the results should then inform what kind of margins you need to apply to safe to treat these patients and what kind of PDV margins you're going to apply to your targets. An example then shown here, this is a test we did on a TrueBeam prior to starting hyper-arc treatments. We took a skull phantom shown here with the top taken off. And the skull phantom included realistic plastic inclusions that looked like, of course, a real human skull with IGRT. So the images shown here show what the phantom looks like internally. And then we can then use this phantom, plan a small spherical target in the center of the patient's skull, and use orthogonal films placed in a film cube inside that phantom to check centering of dose delivery in this phantom setup. And by checking how offset this film exposure is from the center of that film, we can then analyze that with software and determine exactly how good our targeting is for this kind of case. And again, it does include realistic IGRT localization for it is again a skull-like object. So it's a nice test to include that way because we can then have a realistic idea of how good we can be for the localization we intend to use for our patients.
So
of course,
Ron,
yes.
What's the difference between the image 1 and the image 2?
Oh, okay. Again, these are, in this case, two separate films set, as you can see, in this film cube. They are kind of butterflied, as they call it. So it's sort of orthogonally. So you can do this localization in 3 dimensions.
I see. So like one is a sagittal and the other is a coronal.
Correct. Yes, exactly. Yeah. And so in this case, we ran this test prior to our treatment delivery and got a result of 0.5 millimeter offset in this delivery. And so we're happy with that, and that we think we can then treat these patients to sub-millimeter accuracy, given a realistic test. Of course, this is not a patient. This is a rigid phantom that will not move during treatment, so one has to take that into account as well. This is a perfect, stable, non-moving system, and so a patient is not exactly going to be that way. And so one may want to add a further margin of uncertainty to account for, again, the possibility of interfraction motion for these patients. Another possibility for other sites in the body is to use other phantoms. And so this one is available in America from our QA center in MD Anderson in Houston. In this case, it includes a semi-realistic sort of lung density inclusions and a spine inclusion as well. And inside the phantom, they include OSLDs and film, which you can then use to, again, check both dose accuracy delivery and also positional delivery accuracy as well. And so they have, say, orthogonal films that fit through this lung inclusion here. But looking at the profile of these films, in this case, they sent back a report, from the IROC Center showing your measured dose, shown here in blue, predicted planning dose, shown here in magenta, and you can then get an idea from this how well centered these two dose distributions are of exactly how accurate your film delivery is going to be, your dose delivery is going to be. You can even include a motion phantom with this setup and actually test your ability to treat accurately to a moving target. But again, some kind of end-to-end test should be done for, again, any SRS program prior to starting delivery. And these tests, of course, are done to credential centers, in this case, in America, for doing clinical trials to test how well we can deliver a dose.
Ron, we have another question.
Yes.
If I'm a center and I've been doing VMAT treatments, and now I'm going to start doing SBRT and SRS treatments, do I need to develop new phantoms for new kinds of tests, or can I use the same kinds of tests I've been doing for VMAT?
It does depend a bit on how geometrically accurate your current systems are. So that means if you're using like a chamber array to do GQA, if those chambers are fairly large and broadly spread, they may not be accurate enough to sensitively detect sub-millimeter errors. So you need to consider that. Everything should be considered in terms of millimeter accuracy.
Thank you.
So, for example, the film is often used in these cases, and in these two phantom films, which can be read and do very high accuracy. We've also used portal dosimetry, portal imaging, which again is very to verify SRS bonds as well. So something like the film or rapid could be used in these cases. So for multiple METs, this provides another challenge in that you're treating often a large number of targets with a single center or only a few centers, isocenters for treatment. And so we are currently here treating up to about 15 METs at the same time in the brain with VMAT with a single set. So at CT sim, you don't know often enough during the CT scanning exactly what the target is going to be centered. So we set a generic isocenter in the center of the brain, and the treatment plan will then center the treatment at the center of mass with multiple targets. Of course, the further you get from isocenter, the more sensitive these targets will be to localization error due to rotation of the patient. So it's essential that you have a 6-degree of freedom couch for this kind of treatment. Another consideration is that for the variant machine, the HDMLC, the smaller leaves, which should give you a better ability to, again, shape the dose around a very small target, only cover the center 8 cm of the field. So you may want to limit your treatments to that size of a target for or that range of target in the brain. One may also consider using larger margins for off-center targets. If there are, say, 1 millimeter for a central target, you might want to use 2 millimeter for targets which are more than, say, 5 cm from the SSS. There is a good recent paper from a number of different centers doing collaboratively a survey of their considerations for single SSS line-equity surgery of the brain. This was in Practical Radiation Oncology last year. And so this was looking at a survey of the practice at 3 institutions: University of Alabama, Birmingham, OHCI, and UCLA in Los Angeles. Not really consensus guidelines, but just a summary of kind of how they do it at each center. And this includes nice technical specifications, patient selection criterion, and treatment planning guidelines in simple tabular form. So it's a nice way, a nice summary of showing exactly what practice is at several current U.S. centers. Another paper that is out recently looked at doing multiple VMAT, multiple MET treatments with VMAT against the center. In this case, Swiss and German centers, and they looked at 315 patients with 1,087 brain METs using a millimeter PDV margin and using TrueBeam with HDMLC. And in this case, localization with the Brain Lab ExactTrack IGRT system. And they looked at targets with a range of distance from isocenter from 2.2 to 104.7 millimeters. What they saw was really interesting. They saw no difference in local recurrence rates after treatment for lesions which are larger than the median distance from isocenter, in this case, 4.7 cm. And so the survival curve shown on the bottom left over here shows, again, the 2 groups of lesions separated out by a median distance from isocenter. And again, there's no significant difference in local recurrence rates, even though the lesions are further from isocenter. So again, using good localization, 6-degree freedom couch adjustments, and in this case, intrafractional imaging with ExactTrack IGRT, they're able to maintain accuracy of treatment for even lesions which are fairly far from isocenter. So when you're doing these treatments, of course, you need to then register your planning CT to CBCTs taking the time of treatment. So again, this should be done fairly carefully. One thing we have done here is we just use bone anatomy only. If you look at the CBCTs, there's very little contrast in cranial tissue in the CBCT. The bone window does provide a lot of detail that can be used to check the alignments. You want to manually adjust the images, get them close, and auto align. But then, of course, carefully check this visually as you complete the alignment. The field of view should bracket the skull. You want to avoid mobile tissues near the oral cavity, but not narrowing the field of view too much. Otherwise, you might introduce larger rotational errors because of the relatively featureless upper skull and anatomy. And of course, you then want to review the match near your target volume to make sure it's as accurate as possible near the targets. So, for example, on the left is a CBCT of a patient's skull with the default, grayscale window. And again, there's no detail really within the brain itself you can see. But in the bone windows, there's often a great little detail in the bone you can then use to accurately check the alignment of the skull of this patient. And so it's a nice way to view that image and to confirm that everything is matching appropriately. On the left then, showing a very broad field of view, probably too large, which may cause displacement errors in registration. And on the right, the field of view which is too small, which may cause rotational errors in alignment. And again, once you get an alignment, then you want to then look, especially near the target volumes, and confirm that matches as close as possible near those targets. So we've recently started a program for HyperArc treatment, that's a variant product again, which is using a standard setup for VMAT delivery for intracranial SRS. And it includes inherently an interfraction imaging setup where you use portal imaging to confirm the patient during treatment. So again, looking at millimeter tolerances for treatment in cranial distress. So you want to definitely check that your patient's within that 1 millimeter tolerance and check often during treatment. So in this case, you take arc deliveries, and then end the arcs at 0, 180 degrees, and use ports, simple AP or PA ports for these patients to confirm the patient is, again, lying still during delivery. A simple, of course, single port cannot get 6-degree freedom information. You can just resolve shifts in left, right, supine direction, or rotation in the plane of the couch. But this is enough at least to grossly check the patient is not moving during treatment. So our tolerances are here fairly tight, 0.5 millimeter or 1 degree. We do not shift the patient if we see displacement directly on the port. We return them to the couch 0 and retake the CBCT. Again, using a bone setting and using, again, appropriate window level settings, and the DRR makes the localization a little more easy to verify as well. So for example, this is an image of the DRR at the top there for a cranial setup, and then a simple AP port film taken at the same time, for this patient during treatment. And so one can again check that there's gross displacement with the patient, but you really can't see subtle rotations in pitch and roll, but you can see rotations in the cart itself. So this is a check. The patient has moved. It's not a quantitative check of all motions. So if they have moved, you bring them back to cut 0 and retake the cone beam CT instead. And just an example here showing, again, changing DRR settings for, in this case, it's a skull fathom. The default settings for Varian are to use a 50 by 50 DRR window, which is really too large for the cranium. By bringing that window down to a smaller size, one can make the image much sharper and clearer, which will then help match when your therapists get the image as well. And also changes the setting from a default soft tissue combination bone setting to just a bone setting can also make the image sharper and clearer. So these changes in these considerations affect our planning. So in this case, again, we have an HDMLC at our treatment clinic in Pittsburgh. And so we do limit our field of view, our treatment field, to a smaller field to accommodate that, to make sure the wide shots are no larger than, say, 8 cm during treatment. And so that means for a patient with multiple mets throughout the brain, we often have to break the plan up into 2 or more fields. So in this case, we have 9 brain mets in this patient, divided into 2 separate groups, 2 separate isocenters. In order to make things fairly clear for our therapists, we number the GTVs in the plan to make it clear which targets belong to which plan. So one plan might treat GTV 1 to 5, the other GTV 6 to 9. The therapist then will know easily where they need to focus their attention during IGRT.
Ron, just one comment on this slide. So you're saying with your current MLC system, the center high definition HD MLCs are in that center 8 centimeters of the field.
That's correct, yes.
So you want to set it so that you can be as precise as possible when you're treating these areas. So you make sure that everything is within the range of your high definition MLCs. Is that what this says?
That's correct. Yes. Yeah, outside the HCM, then the leaves are now like 5 millimeters in size. So we feel that's not really small enough to accurately define the field around these very small targets.
I see. And is it okay if I just make a quick drawing, because this may be a new concept to some of the centers?
Sure.
So we have our gantry and we have our MLCs, and these MLCs towards the outside in Ron's case are 5 millimeters. Okay, so each of these is 5 millimeters thick, but then closer to the middle is a high definition MLCs, which are skinnier and can make a finer resolution, a more precise shape, which is good for SRS treatments when you want to be precise. Hopefully this is making sense. And so by choosing the isocenter carefully, you can ensure that the targets are going to be within this range where your high definition MLCs are going to be able to shape the field. And you'll be able to have this better accuracy. Each of these is 2.5 millimeters. And in his case, you want to avoid shaping your targets with your more crude 5 millimeter MLCs. Is that making sense? Okay, Kautar says yes.
There we go.
Okay, thank you, Ron.
Thank you. So in planning, we want to deliver the plan such that the targets all get the right dose. It's possible during the plan that delivering dose to targets of the first plan might give some stray dose to the targets of the second plan. So we actually use planning tricks to avoid that happening. That means we'll use the first target. In the first plan, we'll treat high dose to, say, 20 gray to these targets on the red box there. We'll also use constraints on optimization to limit the dose as much as possible to the targets in the second plan in that blue box, to keep the dose limit to, say, less than 0.5 gray in the targets in the second plan. And then by combining the 2 plans together, all the targets will get the correct dose. in order to push for conformity of dose from the target volumes and to push the gradient of dose around these targets, we also use ring structures to do each of these target volumes. And these rings might be set at 5, 10, and 50 millimeters from the edge of the target volume. And then by limiting these rings to some fraction of the target dose, we can then push for better conformity and gradient of dose around these target volumes. And by having one set of rings around multiple targets, which might be fairly close together sometimes, we can keep the dose limits in these rings from interfering with target coverage if two targets are very close together, because the ring will then encompass the targets as a group rather than one target at a time. And so that will let us, again, better control the dose and how it falls off in the patient's brain. So we're trying to get the dose to fall off to at least half the prescribed dose within about 5 millimeters from the edge of the target. That means we'll treat, say, 20 gray at these targets here, but have the dose fall off to at least 10 gray or less within 5 millimeters of the edge of the target, and thereby limit the amount of normal brain getting these higher doses. And then, of course, we'll add standard normal structures to the as well. We always include the optics, the brain as a whole, the brainstem, the scalp, the cochlea. Might consider adding in some things like the hippocampus if we're nearby certain structures in the brain. Because of our rings and the general nature of radiosurgery, the dose fall off is very, very rapid. And so if the target is more than, say, 3 cm away from the edge of a critical structure, it's unlikely the structure is going to get any really high dose. So we may not always need to include all structures and all plans. If we have a target at the top of the brain, we know it's going to give very, very little dose. And if the targets, again, are close by to a structure like the optic chiasm, like the optic nerves, we might want to consider adding a small margin to these as well, what's called a planning risk volume margin, to ensure that they're being well spared, especially given uncertainties in treatment delivery. So just a few small examples then of things which can happen for during treatment. So in this case, this patient had a fairly large rotation. You can see there in the head frame. They're again well centered in the head frame. They're not secure enough in the frame, and they're rotated in the plane you can see here. And so to replicate this position, the therapist in fact took at least 3 CBCTs and about 12 minutes to get this patient in the right position before they could treat this patient. So again, it's much harder to replicate a non-straight setup. And so doing this well in sim helps the treatment accuracy later on. In this case, this patient was just agitated inside the mask during treatment. They were claustrophobic. And so it required the multiple CBCTs to land the patient over time because they could not get the patient to lie still. And so you do want to consider this during your treatments and establish some kind of limit, either time or number of cone beam CTs, before you want to conclude that further treatment may be unsafe for this patient. And medication, some kind of medication to calm this patient down during treatment may be made necessary, applied before the treatment to avoid this kind of situation. So if we focus a bit on the treatment timeline down here, this is in the very end, this case offline review application. We can see at least 5 cone beam CTs taken to this patient over the course of about a half an hour before they could get the patient still enough to treat them. And so each of these represents a cone beam CT taken prior to treatment. And then as the patient is being treated, we also take port films of this patient after every arc. And after in this case, the third arc, we had to in fact shift the patient again, take another cone beam because they had moved, and then realign them and then retreat them for the last 2 arcs. So even during this treatment, even after the patient was calmed down after about half an hour, there was still enough motion that we had to stop treatment halfway through and re-CT the patient and then finish the treatment. So at a certain point, if the patient really cannot lie still, one must then consider, is it really safe to treat this patient if they can't lie still for a long enough to get a cone? And just making the point that automatic alignment software doesn't always work. So in this case, we did our first cone beam CT. We did the match with the patient. Everything looked very good. And the cone beam CT, we took an APPA port. And the software erroneously reported like an 18-degree rotation from this image. And by visual inspection, you can see that this patient is not rotated and aligned very good. So again, it's very important that your therapists understand that they need to not just rely on automatic checking, but also visually check, manually check that this patient's alignment is correct. And so we always, in this case, if we even see like a small shift, a small rotation, we will turn off the corrections in the software and just look at the patient without correction and confirm whether or not they're within, again, our tolerances, which are fairly tight. Again, we want this to be within 0.5 millimeters and 1 degree of rotation before we'll proceed with treatment. So just a few quick conclusions. Good mobilization is critical to success of SRS. IGRT is really required for non-invasive mobilization, including the setup of IGRT and interfraction imaging. 6 degree of freedom of pouch motion is highly recommended to reduce rotational errors during treatment. And really a careful assessment of all sources of geometrical error should inform your choice of PDV margins for these treatments. Thank you.